Dear friends, myself Dr. Nitish Agrawal from MMA Dr. Vasantarao Medical College. I am ortho resident from there. I am presenting a short case of knee. So my diagnosis, the patient is anterior instability, most probably due to anterior cruciate ligament insufficiency with anterolateral instability with medial and lateral meniscus tears, disabling the patient with his daily activities in walking and inability to.
So when we ask you the diagnosis in a short case, we usually expect a short diagnosis. So in an OPD setup, you are sitting and you are writing on the OPD card, this is the diagnosis. This is what we expect. For further discussion, you may bring about other factors in case they are required. What is your short diagnosis? What will you write on this OPD card after you have quickly examined this case?
My diagnosis is left knee ACL tear with medial and lateral meniscus tear.
Both meniscal tear and anterior cruciate
Cruciate tear.
You were asked only to examine the knee joint in this case? You were asked particularly or?
I was asked particularly to examine only knee.
Or there some other findings which I am observing?
He's also having some neurological problem, but I didn't got more time to
Okay, so
examine.
you were asked only to
Yes.
concentrate on the knee joint. All right. Justify this diagnosis.
Sir, I will justify.
Before you go on, you see, there are certain problems which can happen distally or they can be revealed distally. In addition to the instability part or a knee injury leading to a neurological deficit. So please do not say that I was only asked to examine the knee. The distal neurological deficit or distal vascular deficit becomes a part of your knee examination. To give you an example, it's very common to have a common peroneal nerve injury associated with posterolateral corner injuries. So you cannot say that I did not see that. It's a part of your knee examination.
From history, the patient is having a.
So I think to answer his question, do you think was the first thing which attracted my attention as soon as I inspected this patient was in the foot? Because I had not examined the knee and I felt that there is something wrong with the foot. That is the major component which is coming in the picture. Is it related or is it entirely different?
It is not related.
Not at all related.
Yes. He's having problems since birth.
Is it unilateral or bilateral? This neurological problem.
Sir, bilateral.
So this also this is in your favor. Injury is unilateral, but the neurological deficit is bilateral and symmetrical. Okay.
So now you justify the diagnosis.
So on the basis of history, the patient is giving the history of fall. He was standing on a chair and he fell from the chair directly on the knee 2.5 months back. He developed swelling immediately half hour after the fall, and the relatives had to get him up and make him.
What is the
sit.
typical book picture history which is usually seen in ACL case? Where the diagnosis of ACL here, is it fitting into that pattern or is it not precisely fitting into that? What is the classical? Is it precisely fitting into the typical history of ACL here? Is the history supporting your diagnosis? Or in a short case, you have to hit the nail on the head. You have to choose points which are highly pathognomonic of the current diagnosis. Our discussion is just for about 10 minutes. So is this a very important history?
So the patient was unable to stand on his own,
Okay.
and he developed swelling immediately after the trauma.
What sort of swelling?
So he was-
Immediately means within a minute, 10 minutes, half an hour?
Within half an hour.
So within half an hour, if a tense swelling develops, it would usually be a hematocrosis. I think that is highly suggestive of it. There is a possibility. So that type of swelling was there. Then proceed further. So this is the point in the history. All right. This is not a very common history of falling from a chair and maybe sustaining an ACL tear, but okay, let's see further.
On the basis of examination,
On the basis of whatever is most important of the examination. Mic is mostly better. Once he has to demonstrate, he should need a collar mic. Or somebody can hold the mic for him.
So on the basis of examination, I examined the patient in standing, sitting and supine position.
Once again, in a short case, need not say front, back, spine. Just tell the hit the nail on the head. Time is short. You see, in 30 minutes you have to present 3 cases. Long cases sometimes are justified in saying that, but just simply tell us the examination.
So I
Key
got
findings.
attachment test positive on left side,
Okay.
anterior rod test positive on left side, and pivot shift test is positive. These are the in support of my anterior cruciate ligament insufficiency. In support of
Before you perform this Leishman test,
yes sir.
what did you observe? As Dr. Basine had pointed out, that it can be a fallacious Leishman test sometimes. What did you observe before performing the Leishman test? Make him lie down, please. Take the relaxed position. And tell me what did you observe or examine before performing this Leishman test?
Sir, I make my patient relax and
Then do it.
comfortable.
Do it. You said I did this. Rather than I will make, simply do it once.
So I will make my patient comfortable and ask him to relax the
Right, all right.
Yes, sir. So I will flex the knee to 20 degrees. I will hold the femur with my one hand.
Oh, you see, as we were discussing, I think we were highlighting that a PCL injury can be confused with an ACL injury. Was you not listening to this lecture? So, before performing this ACL test, you should be sure of one thing, that this Leishman is not because of a PCL but because of ACL only. What will you do for that? That is a very important event which should precede before you test for the anterior instability or Leishman test.
So
Do
I-
something to convince us that.
So in posterior.
Have you understood the question?
Yes, sir. Yes, sir.
Do it rather than talking. Do it.
So I will flex the knee to 20
I
degrees.
think you are not right. Anybody can correct him, or should we tell him the right answer? Let somebody come forward and forward and try to correct him. What is required before doing a classical Leishman test? Do it. Let us see. So very nice. You see, he is demonstrating is called a sell-out sign. You stand at the level of the tibial tuberosity to reduce the error of parallax. And then what do you observe? Normally the tibial tuberosities are at the same level. So if tibial tuberosity on one side has gone backward, that indicates that there could be a PCL, and during your testing of Leishman, it may be a fallacious Leishman test. So you have to ensure this. And the second important thing is, this is on inspection. What is the second important thing on palpation which you have to ensure before performing the anterior inspection? Yeah, do it. I think you were trying to tell me that first. So you put it into words. Tibial step off. Tibial step off. First, try to do it on the normal side. Anybody else wants to do it, or should I demonstrate? Somebody can come and demonstrate this anterior tibial step off. Do it on the normal side and show us all. So you just move your finger on one side. दोनों तरफ जोर लगाने की जरूरत नहीं है.